Welcome to the University of California, San Francisco Sports Medicine Podcast, featuring Dr. Nira Fundia, Dr. Brian Feeley, and Dr. Drew Lansdown, discussing hot topics in sports medicine and society. We hope you enjoy our podcast and look forward to hearing from you.
All right, welcome to this week's edition of 6 to 8 Weeks. Dr. Pandya is off in the operating room doing something probably moderately important. Today we are going to talk about knee MRIs and what they are, why we get them, and how to interpret your complex report when it comes from the radiologist. So Drew is our expert liaison between radiology and orthopedic surgery. So first off, I thought I would ask you some questions in a fact or fiction type manner. This worked really well when we did the Achilles ruptures and you learned about Brad Pitt. So probably the most common one we get is this fact or fiction? If you have an MRI, well, you don't need x-rays of your knee.
I would say fiction. And the x-rays and MRI, they actually give complementary information. And the x-rays can give us a better idea, like with the knee, like what the joint space looks like, especially when somebody's standing. So sometimes you can have an MRI, you can see the structure, you can see the soft tissue well, but that overall appearance of the joint, the x-ray gives a lot more complete understanding of what that looks like.
Yeah, I think that's a good point. One of the things that we do when we get x-rays is we have you stand up. And for an MRI, you're lying down. So that weight-bearing view is really important, especially as you get into your 40s, 50s, 60s, and 70s. And seeing how the joint aligns is super important. And it also lets us see things like bone spurs, which is part of our grading scale and predicts whether or not you're going to get better with some surgeries, which you can't actually see with MRI nearly as well as you would think. So an MRI seems much more complicated. Fact or fiction, it's a lot of radiation.
So that's an interesting one. And it's not ionizing radiation. And so when we think of the bad types of radiation, like the ones that, alter DNA, can increase risk of cancer, like that's ionizing radiation. If you, for an X-ray, for a CAT scan, other medical imaging, those do use ionizing radiation. But an MRI is non-ionizing radiation. So it's radio frequency waves, but it's not harmful in that sense. So, it's actually a really safe test. And, it doesn't have that same type of risk that maybe repeated CAT scans would have.
Okay, so dumb it down for everybody. Pretend you're talking to somebody like me. How does an MRI actually work?
And it's magic. Probably the simplest explanation, but when we're looking at the body, like it's the hydrogen atoms in the body, like in water, so hydrogen and oxygen, but the magnetic field of the MRI scanner lines those up, and then you send little pulses of radio frequency waves that disturb that, and then it looks for the signal as it comes back to that aligned position. So it's just based on the water molecules, and depending on the properties of tissue, that shows up as a different signal, which then gives you a different image. But the long and short of it is magic.
Yep. Okay. So you're going to get a David Copperfield-like scan. Okay.
Yep. Yeah.
So fact or fiction, if you're claustrophobic, they can be tough to do.
That is fact for sure. And it, it is a long, narrow tube. And, I'll tell people, like, it will make a lot of noise. It's narrow, but, there's not going to be anything that touches you. But there are people with like more extreme claustrophobia that just can't, be in a confined space like that. And, there are times where, taking medication, there are open MRIs. Unfortunately, the pictures are really bad usually, so it may not be the same option, or alternative scans that we can look to in those cases.
Yeah, I think one of the things is patients often may have had an MRI like 15 years ago and say, well, I barely tolerated it. I don't love elevators, but the technology has really changed. I recently took one of our kids to get an MRI of their knee, and it's amazing. You get to watch a movie during it. So she watched part of Black Panther. She was a little disappointed the MRI was over, but there's a whole technology in putting non-metallic things into the MRI room because it's a big magnet. You can't have a VCR in there. Nobody knows what a VCR is. An iPad. But they have all plastic viewers, so you don't even know what's happening as long as you can put those on. And I think it's a really great technology. She didn't even hear all the noises, really. She said it was off in the background. So I think even for people that are claustrophobic, the technologies that are allowed now within that MRI machine make things totally different. All right, so fact or fiction. If you're getting an MRI of a knee, you might as well look at the entire body all at once. You're in there, might as well get a whole body scan.
Yeah, so unfortunately fiction, and can see where that would make sense. But when you're getting an MRI, usually you'll have, it's called a coil, but it's a specific component that just goes on the body part that you're scanning. And that lets you get really good images of that specific area. And then as soon as you, like if you were to just look at the whole body all at once, all the pictures are going to be really bad. And so you're not going to see anything. And then, the flip side would be to, put a coil on every area, but then you'd be in the scanner for the whole day. So it's a very focused study. And, I think getting just the part of interest is, the best way to go.
Yeah, that's definitely something I've learned recently, partially because I've had enough MRIs, but over my experience, I thought at first it was just basically, well, it's just going to take more time. But the reality is both on the computer engineering side, it takes a lot to set up on the outside of the scan to get the right scans, and you need the right coil. And it's not one coil being moved body part to body part. It's a different type of coil depending on what we're looking for. So It's really not nearly as easy. All right, last one. Fact or fiction? The guy who invented the MRI got a Nobel Prize.
Oh, I'm going to say fiction by the question, but I think there was there was a Nobel Prize related to the MRI physics, but I'll say fiction.
All right, you're a really good test taker. So Raymond Damadian, who is a physician in New York, invented this in the mid to late 1970s. For reasons unbeknownst to Wikipedia, he did not get the Nobel Prize, but the people who wrote the computer code to interpret the MRI got a Nobel Prize, and it was never shared with him. So unfortunately, the inventor of the MRI, not a Nobel Prize winner. The person who knows how to interpret the MRI, Nobel Prize winner. That's why orthopedic surgeons who interpret the MRI are a little bit more important.
Yeah, maybe next up for the Nobel Prize.
Yeah. No. So what I thought we would do is I'm going to take you through a case that's a little bit made up just because we didn't want any patient confidentiality issues, but this is a typical case of somebody who presents with knee pain. And I'm going to go through the case, and I want you to interpret it the way an orthopedic surgeon interprets it. So this is a 56-year-old female, and it says her meniscus has a complex degenerative tear of the body and posterior horn of the medial meniscus, including a radial component at the posterior horn root junction. So what does that mean to you?
Yeah, so I think what I'll tell people is when you're looking at the language in a radiology report, like the radiologists, they will describe everything they see, and they're great at it, and it's really helpful. But some of the descriptions, it starts to sound like, it's amazing that you're even walking. So it's a complex degenerative tear. Like that sounds terrible. But that complex means it's just torn in a few different planes. So it's like not one clean tear, but just more fraying or even like shredding of the meniscus, which doesn't sound good, but that is kind of what happens in as the meniscus ages, as our knees get older, that tissue breaks down and we have that complex tearing. And then the radial component, that I would want to see exactly what that looks like. A radial tear of the meniscus gets a little bit concerning because that disrupts just basically how the whole meniscus works. It can also be in that or that spectrum of arthritis, or that may be something that's more acute, more of a problem, and something that, we need to talk more about, even surgical treatment options.
Yeah, I think even though complex and degenerative sound the worst when you look at it, we really look at whether or not there's a radial component or a component that extends into the root, on whether or not there is something that needs to be addressed surgically sooner rather than later. All right, so this is an older patient. It's not somebody with an ACL tear, but this says for the cruciate ligaments, anterior and posterior cruciate ligaments are intact, but there's mucoid degeneration in the ACL. What does that mean?
Yeah, and so it means that the composition of the ACL is just not completely normal ligament structure, that there's some degenerative change. And that, again, is something that we see with aging primarily. But on the scan, just see that the tissue composition isn't 100% normal.
Yeah, I think for what we look for is absence or complete tear of the ACL. There's very rarely partial tears of the ACL. And mucoid degeneration has never been associated with an increased risk of injury in the ACL, and it's never been associated with pain. So it's kind of, as far as I can tell, it's a pretty normal finding as we cross the 30 to 40-year-old barrier. All right, MCL and LCL, so your collateral ligaments on the inside and outside of the knee, bowing of the medial collateral ligament.
Yeah,
that's bad. It's bowed.
It's bowed, and that we can see with arthritis, just as the joint changes in shape. You can have some redundancy, some bowing, and it can be too that like a bone spur is pushing out on it, or the meniscus is pushing out, things like that. So it's more, what's causing the bowing, but probably, related more towards arthritis.
Yeah, I think one of the things that we, especially during ski season, is we get a lot of MRIs that show partial tears or sprains of the MCL, and those are very different. We see grade 1 sprain, grade 2 sprain, grade 3 sprain, and those suggest a partial disruption of the MCL. But the nice thing about, even if you have a complete MCL rupture, more than 95% are going to heal on their own. So I tell patients, for even if you have what looks like a horrible MCL injury on the MRI, for the most part, those are going to heal up absolutely fine. What about severe tendinosis of the popliteus?
The tendinosis is another, it usually degenerative finding, can be like overuse related, can be related to injury. The popliteus is one of the tendon actually goes through the knee joint and helps stabilize the knee. But that's just like some signal change on the MRI, likely on that wear and tear spectrum when put together with the rest of this, but probably not something that's going to cause pain, cause functional issues.
Okay, so patellofemoral joint, this says the patellofemoral ligaments are intact, which means no dislocation. Full thickness cartilage loss of the patella with mild subchondral marrow edema. What does that mean to you?
Yeah, so the cartilage is important. That's the smooth lining on the end of the bone or on the patella on the undersurface of it. And then whenever that's lost, that can be painful. That is either arthritis, or you can have just an isolated cartilage injury. And whenever it's full thickness, that means you've lost that complete layer in that area. And then the subchondral marrow edema means the bone is reacting, like there's some swelling in the bone due to the loss of cartilage. And so that could be a significant finding. Put together with the rest of it, it may just mean that we're looking at an arthritic knee. But we'd want to see exactly what that looks like and where their symptoms are to see if that's the problem that we're dealing with.
Yeah, I definitely see the difference between a small area of full thickness cartilage loss and that with subchondral edema or swelling within the bone as maybe asymptomatic to likely a potential source of pain. What about low-grade chondral thinning of the femoral trochlea with chondrosis?
So the chondral thinning is just thinning of the cartilage, and that just, I would interpret it as their cartilage is not completely normal through that area, but it's not also that bad, like just a low-grade thinning. And that would really fit more on that spectrum of, the whole knee is breaking down. Like you've got some areas that are all the way lost, and then others where they're, less so, but not normal. It's not just, one isolated area, but and chondrosis is just the composition of the cartilage looks abnormal. And yeah, so it sounds like just that cartilage layer is breaking down.
Now, yeah, so breaking down sounds really bad. Is that necessarily a bad thing when you say the superficial layer of cartilage is breaking down?
Not necessarily. And it's, can be, especially as we lose more cartilage, can be more and more symptomatic. But some of that, if you scanned a completely asymptomatic knee, like the person feels great, they're active, doing everything, they're 65, you'll see a number of these things on that scan. Like that can just be there where the cartilage is a little thin, you've lost it in some areas, there's some inflammation, and they say, well, my knee feels great, I don't have a problem. It's really, a lot of those can just be incidental findings.
Yeah, I think that's a good point. One thing that we always need to remember is that cartilage doesn't have any nerve endings. So a little bit of chondral fissuring, a little bit of cartilage loss, your body is made to withstand that absolutely fine. So once you have bone marrow edema, I think it's a little bit more important. And once you have symptoms, and especially changes that we see on x-ray, we get a little bit more concerned about the level of arthritis, but it still also goes down to the patient. Some patients are very symptomatic. Some patients aren't very symptomatic with different levels of cartilage loss. All right, last one. So partial cartilage fissuring on the central weight-bearing medial femoral condyle with low-grade chondral thinning and signal heterogeneity within the lateral compartments. That's a lot of words. So what does that mean to you?
I would say overall, it again, that the knee is breaking down. And then it also sounds on the more mild end of the spectrum, but that partial cartilage fissuring, the location, the central weight bearing portion, that's where, you're transmitting load, your weight's going through it. So that could be more significant, but the partial fissuring really doesn't sound too bad. And I think, the other thing to remember with MRIs, the level of detail on them is so high that you will see tiny little things like little fissures in the cartilage that can just be completely normal. So some of these, it may be yes, it's not 100% normal cartilage, but it's also not that bad.
Yeah, I like to think of a radiologist as kind of like the Associated Press. There should be no bias to the reporting. And they shouldn't be telling us, well, this looks like January 6th wasn't really a big deal, just a bunch of people outside the White House with a little bit of chondral thinning. It's more along the lines of, this is what we see. This is subject to the interpretation by the orthopedic surgeon and the patient and the physical therapist. All that being said, what are your key indications for when somebody comes into clinic and you say, you're going to get an MRI? What are the key things in their history or their physical exam that says this warrants an MRI versus physical therapy and an observation and wait and see?
Yeah. And so a lot of it will be based on, if there was an acute injury, if it was, one specific moment, I was skiing, I twisted my knee and felt a pop. I was playing soccer, and then also, did the patient feel or hear a pop as it happened? And then swelling in the knee is more concerning finding, especially when associated with an injury. Really start thinking of a meniscus cartilage injury. And then, on their exam, if we're picking up, ligament instability, there are tests for, meniscus tears, findings that would line up with a cartilage injury, that will prompt us towards getting an MRI. And then a lot of it too is, is this something that it should be dealt with surgical operation. And so if, you're evaluating the knee and it's like, well, wouldn't even consider surgery on this, then the MRI may not be helpful. But, it can help us understand, is there something we should intervene on to, or, sometimes it is just changing our rehab recommendations too. The MRI can help with that.
Yeah, I think for me, it's acute injury, swelling without a previously diagnosed cause. Whether or not there is something that is impeding their ability to do their work, sports, or quality of life that hasn't been otherwise diagnosed. So arthritis doesn't need an MRI. Potential ACL injury probably needs an MRI. New onset meniscus injury, often even those we can treat with non-operative management. A variety of patients will get better, about 70% will get better without actually needing to jump to surgery. All right, well, thank you very much for your time today, Drew. Enjoy the operating room, and hopefully this will be informative for people who have to sit in a long tube and watch movies.
Yeah,